Okay, good afternoon. I hope you had a nice lunch, a good lunch, and that you rested a little bit. I have some question. I got some question by you, and now I try to reply to some of them, the most interesting. And the first question is this. So the first question is, each activation of the screw gives 0.2 millimeter of expansion from both sides or from one side. Of course, 0.2 millimeters, half on the right, half on the left. The second question is, in protocol of the treatment, it is written 6 months. You said to use the expander as retainer during 1 year. Can you clarify, please? I don't know what protocol are you talking about. Probably the protocol of Haas or Hyrex of 20 years ago. I'm not doing a treatment whose aim is only to expand the maxilla. We are doing a treatment which aims to align the permanent teeth, the incisors and the permanent molars. So I never take out the expander before 1 year. My expanders always stay in the mouth at least 1 year, because it is demonstrated in 1960 that the hard palate, the palatal bone, relapses within 1 year. So never take out the expander after 6 months. This protocol is wrong. 1 year is the minimum, but I never take out the appliance until the full eruption of the lateral incisors. I want the permanent lateral incisors fully wrapped, then I think about taking out the appliance, but never less than 1 year. Do we need anesthesia when we equilibrate, when we grind the occlusal surface of the second molar? No, never. I never use anesthesia for occlusal grinding, not even for the slicing. Also for the slicing, I never use anesthesia. If you do the slicing at the right time, during the eruption of the adjacent teeth, the lower canine and the second deciduous molars never need an anesthesia. During slicing, you just have to use an abundant water spray. So another question is this: how do I explain the parents the importance of slicing the canines and second milk molars? I explain to them that we have 3 alternatives. They can choose. One alternative is to wait and the adjacent teeth, the premolars or the lateral incisor, will erupt crowded. Then we will use appliances in the future to align it. Second alternative is the extraction and the space maintainer, but is more expensive and the kids don't like extraction. The third alternative is the slicing. If they don't like, we cannot do it. But of course, if you don't do something, it will happen something else. We have only these 3 alternatives. The parents can decide what alternative is the best for the kids. A question about using a rapid palatal expansion in the mixed dentition when the upper first permanent molars are not yet erupted. Sometimes we see that upper permanent molar cannot erupt, but the age of a patient and stage of eruption on the other teeth is okay. What do? if the permanent molar doesn't erupt, I take a X-ray, of course, a panoramic or something else, and first of all, I check that the permanent molar is not infraoccluded inside again against the deciduous second molar. If it is not infraoccluded in the resorbed root of the second milk molar, I wait. Probably is only a little bit late, but I prefer to expand when the permanent molars are at least minimum more than half of erupted. So if the permanent molars are not erupted, I wait and I try to understand if there is some particular problem. Other question? No, I responded to this. There are another interesting question about mandibular shift, but I will give you the answer during my lecture. Okay, so we can start the third part of our day, and the title is Class 2 Subdivision Asymmetry, which means unilateral posterior crossbite. And is a main problem. It's a main problem. We have to sometimes we have to expand, because in this situation, class 2 subdivision means that you have class 2 in one side, molar and canine class 2, and the molar and canine class 1 in the other side. Class 2 subdivision means an asymmetry of the midlines of the jaws. Quite often is associated to posterior crossbite. So the expansion is indicated in many class 2 subdivision. There are also class 2 subdivision without posterior crossbite. Anyhow, in one side we have a class 2, in the other side we have a class 1. And the midline are usually deviated. So the topic is asymmetries. Asymmetry is a huge field. A class 2 subdivision is only a little aspect of an asymmetry. When we talk about asymmetries, sometimes we are in front of a patient who is asymmetrical everywhere. From the eyes until the feet. So the malocclusion is one aspect of the asymmetries. What I mean when I say asymmetry, and we have to explain this point to the parents before treatment. Asymmetry means, for instance, that we have a deviation of the mandible, a deviation of the midline, like in these cases. There is a cant of the occlusal plane. Usually we take as a reference line, the vertical line which is passing through the filter of the upper lip, and in the trachea, the point where the hairs are in the middle of the head. Usually the center of the suture between the nasal bones is also a good point to draw a vertical line. So the upper lip filter the suture between the nasal bones and the trachea. Sometimes we take the eyes, but this is wrong, because many kids have one eye which is higher than the other one. The ears also is not a good point, because the ears are sometimes display one higher and the other a bit lower. So the vertical line is important, and on the vertical line, I tell you again, passing on the filter and in the middle of the suture between the nasal bone, between the eyes, we draw an horizontal line passing on the eyes, and an horizontal line, of course, very important, on the occlusal plane. These asymmetries sometimes take place everywhere in the human body. is very frequent that if you look at a kid with attention, you will see that there is an asymmetry not only in the mandible, not only in the teeth, but also in the face, in the cranium, in the skeleton of the cranium, in the head, in their spine, shoulder, lower arms, so the legs, and sometimes the feet. So before starting a treatment, we always have to check the kids in total, and in many patients, I ask the parents to do a visit to an orthopedic doctor or to an osteopath or to a professional who is working on posture in order to take care of the different part of the asymmetry all together with the other specialist. Usually it is a matter of orthopedics, or it is a matter which can be taken care by an osteopath, a good osteopath. Anyhow, always inform the parents that there is an asymmetry which is much beyond the teeth, the occlusion. Of course, we are interested in the head, more specifically in the facial bones, the jaws, upper and lower bones, and we have to learn how to do and what to check from the very beginning. So the bones are a problem. There is an asymmetry of the bones, and there is an asymmetry, of course, in the occlusion. If we look at the bones, the jaws, only the two jaws where the teeth are fitted, there is very little literature. This article is interesting, 2010. If we look at the skeletal anatomy, using a CBCT investigation, which is a good way to measure in the 3 dimension of the space the anatomy of the bones, the researchers found that the etiology of a class 2 subdivision of an asymmetry of the jaws is primarily due to an asymmetric mandible. The vast majority of the patients have an asymmetry in the lower bone, the mandibular bone. A mesial positioned maxillary molars and the class 2 subdivision, which involves also the upper jaw, is less frequent. Then, apart the bones, if you talk about the teeth, there is quite often a double problem, a little bit in the upper jaw, where the molar one side is a little bit more forward, and the lower molar, which is inserted in the mandibular asymmetric bone, is a little bit more distal. So even if we take care only to the face, only to the jaws, only to the teeth, it is difficult to find a clear-cut mandibular asymmetry or tooth asymmetry. It is a mixture between teeth and bones. Anyhow, the most important contributing factor is the mandible, a deviated mandible. Sometimes is a shift, sometimes is a structural asymmetry, and a little bit the maxillary molar forward above in the upper jaw, the mandibular molar back in the mandible. The diagnosis, anyhow, starts without Combin CT. We cannot ask a Combin CT or a CT scan to all the patients in order to measure all the part of the asymmetry. Diagnosis starts when we do the first consultation, and we immediately have to check on the patient what are the most relevant etiologic factors. In this case, as you see, we have a canting on the occlusal plane, but also the upper midline is deviated. The occlusal plane is deviated. This deviation can be seen also on the lips. When you are in front of this face, a face like this, and if you are a good observer, you will find a lot of points which are asymmetrical. A good picture, a well-done picture, this is very important to be done before treatment. A picture from the face, from the front, well done. Well done means with the patient in front of you. You have to see the same amount of ears, the right ear and the left ear, same, and the patient must not be turned on the right, on the left. If you have a good picture, you can see a lot of things. For instance, in this case, if we take the picture, if we rotate it like this, you see that the face is totally different. If you bring the two halves of the face and you compare by mirroring it, the two left and the two right hemiface, you see that there is a huge skeletal asymmetry. So here you see what we are talking about. We are talking about a problem which is much bigger than the orthodontic treatment. Of course, our goal is not to make a cranium, a face symmetrical. Our goal is to fix the occlusion and to fix, if possible, some minor aspect of the skeletal bone. It is impossible to check, to visualize the aspect of an asymmetry from this position. When you see the patient the first time, you do the first consultation, if the patient is sitting on a chair like this, you will never be able to see all the aspects of the asymmetry. You need to check the patient in front of you. Patient must stand up, must stand in front of you. What you see on the right is my favorite working position during the day. Also, when I check the patient during orthodontic treatment, this is the best way to see an account of the occlusal plane to define the most important factors of an asymmetry. So, the first consultation, what you see on the left, and during treatment, what you see on the right, must be done with the patient standing in front of you. At that point, you can see many things which are not visible when the patient is sitting. If the patient is a young patient, you must be at the same height of the patient. So if it is a little patient, I work on the knees in order to see where is the asymmetry. So I try to understand the main point of the asymmetry since the first day I meet the kids. This is the day of the first consultation, first visit. I place the kid in front of me and I check the occlusal planes, the asymmetry of the nose, the eyes, the teeth, the midlines, everything. Then I ask the patient to stand on both feet and I try to see, to realize whether there is some indication to ask an osteopath or a specialist in posture to do a diagnosis also from the neck to the feet and to define a treatment plan all together. But what is important is to recognize immediately if there is an asymmetry in the upper jaw. To see an asymmetry in the upper jaw, if you ask the patient to look at the ceiling, you will see a lot of things that before you never were able to see. So ask the patient to look at the ceiling and look at the canines, look at the molars, look at the tip of the nose, and try to understand if there is an asymmetry of the upper arch. For instance, when the patient is looking at the ceiling and you are in front of him, of her, you will notice immediately, much easier, if a canine is more mesial than the other one. Not only you will be able to see the midline, the upper midline, but you will see the antero-posterior position of the canines and of the molars much better. Much better. And if you see a problem like this, of course, it means that you have to do a treatment which is totally different than when you are in front of a mandibular asymmetry. So this position, with the patient looking at the ceiling, is very important to check very well the antero-posterior position of the canines and of the molars. The midline, of course, is much easier to be seen from the front. In this case, the midline is deviated also because there is a missing lateral incisor. There is a deciduous incisor which fade away too early, and so there is a deviation of the midline. The same happens when you lose a canine, of course. When you lose a canine, it is obvious that the lower teeth will move on the other side. So when you see an asymmetry of the midlines, doesn't mean that there is a mandibular shift. Could be an asymmetry of the upper jaw, which is important to notice also on the back teeth, but you have to check immediately if there is a tipping of the incisors. Usually the tipping is due to the absence of one tooth in one side. Okay, to go back to the main definition of a class 2 subdivision, we have to simplify the more we can the diagnosis. And so I recommend you to divide the class 2 subdivision in two types. Types 1, deviation of the mandible, the lower jaw, and with the jaw, the teeth are deviated to one side. So the lower midline are deviated and the molars are more in the back, in the side of the deviation of the class 2. Type 2, class 2 subdivision type 2 means that there is a mesial positioning of the upper molars or the upper canines on the class 2 side. So class 2 subdivision type 1 means problems more in the mandible. Class 2 subdivision type 1 means that you have in one side of the maxilla the molars and the canines forward. Then, of course, you have to check the stability of the joints, the stability of the TMJ, which means the stability of the jaw, which means the presence of the absence of the mandibular shift. To check the mandibular shift, to check occlusal precontacts, occlusal prematurities, to check whether there is a COCR discrepancy, patient must sit down. The head must be well positioned against the chair, and then you slightly manipulate the mandible in order to place the TMJ in the right position and in order to understand if there is one tooth who is touching before the other teeth. Also kids can tell you if there is one tooth which is touching before, too early. This is something very important to be written and to be recorded at the beginning very well. Of course, when you are in front on a deviation of the midlines like this, can be everything. Can be a mandibular deviation, can be a mandibular shift, can be the midlines or the dental midlines deviated because of the absence of one tooth on the other. So a unilateral posterior crossbite can be a wide mixture of so many problems related only to the teeth and to the facial jaws. Of course, the TMJ stability is the most important thing. We want to do a diagnosis with the condyles well positioned into the fossa, right and left in the same way. So I manipulate slightly the mandible until I feel that probably the condyles are in centric relation, we say, no, they are well positioned in the fossa. And at that point, I ask the kid, tell me please if there is one tooth which is touching before the others. And the kid says, yes, I feel that there is the upper left canine or the lower left canine, the canines in the left, which are touching before. Ah, thank you. This is the tooth which touches too early. When they want to close the mouth and use the molars, of course they have to shift, in this case to the left, and the condyles, of course, move. The right condyle moves out and the left condyle moves inside the fossa. This is a CO-CR discrepancy, which is quite common during the orthodontic treatment, but must be recognized in this kind of malocclusion before treatment. So a little bit the bones, the jaws, a little bit the teeth, the molars, the canines, the incisors, and even more important, where are the condyles positioned, whether there is or not a CO-CR discrepancy. It is clear that if you have a CO-CR discrepancy, diagnosis must be done in centric relation, what you see above, not what you see below. So this patient is not a class 2 on the left side. This patient is not a full class 2 on the left side and almost a class 1 in the right side. Is a class 2 in both sides. And it is enough to expand the maxilla to allow the mandible to stay very comfortable in the middle of the maxilla. So let's go back to our patient and try to define other problems. In this patient, we have the vertical line, which is probably the most reliable line to check, to have as a reference line to check the asymmetry. The bipupillar line is very debatable. What are the targets? What part of this malocclusion should be treated in the mixed dentition and what should be treated in the permanent dentition? In other words, what are the indications to intervene early in this kind of patient? This is a class 2 subdivision 1. So there is a slight deviation of the mandible, an asymmetry of the mandible. Could be a CO-CR discrepancy or could be a skeletal asymmetry. In this case, it is a skeletal asymmetry. There is no posterior crossbite and the mandible is very stable together with the TMJ. So there is no shift. There is a little bit, there is a wide part of the malocclusion related to the presence of asymmetry of the upper arch. You see the upper midline is deviated. You see that there is probably the left canine and molars in the upper jaw a little bit more forward than the lower molars. Then there is no canting on the occlusal plane. This is a big problem, and in my opinion is not a problem, the cant of the upper occlusal plane, which must be treated in the early treatment. Much easier to treat it after the transition. And then in many class 2 subdivision, there is not only a class 2 subdivision, there are other problems, extra problems. Crossbite, crowding, protrusion, COCR discrepancy, tooth migration. Well, I think that in the mixed dentition, we must correct this part of the class 2 subdivision malocclusion. The crossbite must be corrected early. Crowding must be corrected early in the mixed dentition. A COCR discrepancy should be corrected the sooner we can, as soon as possible. And deviation of the lower jaw of the mandible is something which can be treated some ways in the early mixed dentition, in my opinion, after it is impossible to be corrected. So usually if there is a class 2 subdivision type 1, even more, if it is associated to crossbite, crowding, or mandibular shift, I try to treat it early, in the early mixed dentition. On the other hand, if it is a problem of class 2 subdivision 2, asymmetry in the upper teeth, occlusal planes, I wait the permanent dentition. And eventually before I treat solve the extra problem, the crossbite and the crowding and the COCR discrepancy. So this patient is a class 2 subdivision 2 type 2 malocclusion. It means that the main problems are in the upper jaw. There is a deviation of the upper midline. So the upper midline is deviated to the right of the patient, and there is a cant of the upper occlusal plane. There is a mesialization of the upper left molars and canines. I think this patient must be treated more efficiently with a better cost-benefit ratio in the permanent dentition. So I see the young kid, I take the records, I do a diagnosis, I talk to the parents, but I don't do any kind of treatment if there is no crowding, no crossbite, no mandibular shift, no evident deviation of the mandible. It is mainly a problem of the upper jaw. In the upper jaw, it is a dental problem which can be treated much more effectively in the permanent dentition. So I wait the permanent dentition, and permanent dentition doesn't mean 14, 13, means when the patient is cooperative, when the patient is motivated, when the patient brushes the teeth quite well, and it is possible to achieve a good result in a short time because there is a good compliance. In this case, patient was motivated when he was 16. 16 years of age, high school, and he is motivated to treat the malocclusion. As you see, he is a class 2, also skeletally, very slight, but there's a slight class 2 skeletal malocclusion. This is the slight protrusion he has, but the face is very short, so there is no problems with the lip posture, and we can treat this case as we want. What I decided to do was to fix the malocclusion in the permanent dentition with extraction. Why extraction? Because extraction is the best way in this malocclusion to fix very well and in a shorter time the class 2 subdivision type 2. It has the mesial position of the upper left canine, the upper midline, and in the same times I will also be able to improve a little bit the crowding. So even if he is a hypodivergent pattern of growth, even if there is just a little bit of crowding, nothing, let's say, no crowding, I decided to extract 4 teeth, 4 premolars. But since I want to correct the asymmetry, I will not extract the premolars in a symmetric way. I extracted all the second premolars except in the upper left hemiarch. I extracted the upper left first premolar. So with an asymmetrical strategy of extraction, it will be even more faster, the correction of the malocclusion. So I close the spaces, distalize the upper left canine immediately, and this is one of the last steps of treatment. The message for you is, if you have a problem in the upper jaw, mainly in the upper jaw, and there is no reason, no indication to an early treatment, wait. There is no reason to treat this patient in the mixed dentition. At the end of treatment, the result is good, the occlusion is good, the profile is like before, didn't improve, didn't worsen. The protrusion improved a little bit, but I worked with maximum anchorage on the incisors, on the lower incisors, in order to prevent a wide opening of the interincisal angle. This is the posture of the lips at the ends, more or less is acceptable at the beginning and also after treatment. 4 years post-op, 4 years after the end of treatment, you see the stability of the occlusion, the improvement of the occlusal contact, and you understand that this was the right treatment. Of course, he had a skeletal asymmetry before, he had a skeletal asymmetry also now. The mandible is deviated. He had an asymmetric mandible, it was not a shift, and we can fix it only surgically. There is no reason. Okay, this is another example of class 2 subdivision type 2. This is a young kid, as you can guess from the face. You see he is in mixed dentition, and he also, like the patient before, is a class 2 subdivision type 2. Type 2 means the main the class 2 is due to the upper molars, upper canine on the left side, which are more mesial. So the upper left hemiarch is more mesial. You see the deviation of the upper midline, same than before. You see that the upper molars are one forward, one on the back, a good lateral head plate. Let you understand many things about asymmetry. You see that the lower molars are on the same line. You see that the occlusal plane is a double occlusal plane, and also the mandibular border are double. Of course, in the left, the occlusal plane is a little bit higher. So we can do, we must do diagnosis from the very beginning and understand immediately how much the class 2 subdivision is due to a mesial migration of the upper molars and canines. This is something which is indicated to be treated in the second phase of treatment. But in this case, not only I noticed a class 2 subdivision type 2, he was also crowded, narrow maxilla, and posterior crossbite. If there is a posterior crossbite, probably there is a narrow maxilla. We will have the lateral incisors crowded, and he will become a real class 2 subdivision 2 malocclusion with the lateral incisor crowded. Here you see very well the upper jaw with the canines a little bit more mesial on the left side, the molar as well, while the lower molars are on the same line. Upper deviation of the midline could be due to the delay in the eruption of the right lateral incisor, but probably is due to the fact that all the upper dentition is deviated to the right of the patient. Is a short face, typical class 2-2, but is a subdivision. There is an asymmetry, and there is problems which must be treated early. So what I will do, I will treat the crossbite, I will treat the crowding, and since I have to do an orthodontic treatment for other reasons, I also will improve the position of the maxillary molars on the left side. So the indication to distalize the upper left molar is not the presence of a class 2 subdivision type 2. The reason why I will also distalize the upper left first permanent molar is that I had to do an orthodontic treatment in the mixed dentition for other reasons. I must do a treatment to fix the narrow maxilla, the unilateral posterior crossbite, and the crowding, and a slight, very little in this case, COCR discrepancy. This patient has a very, very minimum, almost nothing COCR discrepancy. Why the screw? Why the screw? Because if I want to distalize a molar, I need a full, a reliable anchorage. I never expand a molar if I have a traditional RPE banded on the decidus teeth, because you lose a lot of anchorage. So I decided to use the screw to have a good anchorage, which will allow me also to distalize the upper left molar. This is the expansion, a real expansion. This screw is 12 millimeters. You see written on your left. 12 millimeter screw. I use almost the whole screw. At the end of the expansion, also almost 12 millimeters, 11 and a half. The crossbite jumped, self-corrected once again. You expand and the crossbite now doesn't exist anymore. So once again I corrected the crossbite, and now it's time to improve a little bit the slight mandibular asymmetry of this patient. And in this afternoon I will talk about resin bite blocks. Resin bite blocks means, in this case, is a twin block on the left. Means to bite blocks in order to drive, to keep the mandible where I want. In this case, I wanted to overcorrect the lower jaw, the mandible, to the right of the patient. Overcorrection is necessary because usually when we do this kind of manipulation of the position of the mandible, there is a relapse. And I'm trying in this way to improve the class 2 subdivision also by moving the mandible a little bit to the right. I know that the class 2 subdivision is mainly due to the upper teeth, but I also want to improve the asymmetry of the mandible. Of course, these bite blocks, these resin bite blocks, these occlusal resin composite bite blocks are higher, thicker on the left because he had an asymmetry of the lower mandibular border and of the lower of the left part of the occlusal plane. So by doing a thicker bite block on the left, I will be able to improve the asymmetry of the mandibular bone. After this is July. Above you see the occlusion. The patient must keep the mandible where I want. This is the same day. You see half of the twin block on the left part of the left hemiarch in the lower molars, half of the twin block on the left on the upper deciduous molar. Then when he closes, he must close like this. This is April after 8-9 months. And you see that the permanent molars, also on the left, from an open bite, go down to a good occlusion. But you also see that the midline, I overcorrected the midline, relapsed. And I tell you again, a little bit of overcorrection when you want to improve the mandibular asymmetry must be done because the relapse is absolutely normal. Don't forget that this patient started in a full class 2 with a cross bite. The expansion, the orthopedic expansion fixed the cross bite, but not the class 2. The bite blocks move the mandible to the right, an overcorrection. Now the left molars are in class 1. Now I wait for the eruption of the untouched permanent teeth until they are in class 1. Believe me, if it stays like that, second phase of treatment will be much easier. The problem is that I don't know if it is stable. Of course, I remember very well that there is also the necessity to distalize the upper left molars and canines. To distalize the molar, I prefer to use a long wire. So once again, passive, the wire is very passive on the deciduous canine. The deciduous canine are very little. You cannot place the bracket where you want. In this case, the bracket is the same size of the deciduous canine, so there is no way. You have to place it there. But as you see, I use a stainless steel arch wire, and before the upper left deciduous molar, there is a step to make the wire passive both on the deciduous canine and on the right deciduous molar. I want the wire passive. Then there is a coil spring to move back the upper left permanent molar, and the permanent incisors can be optimized during this phase. So it's a very complex structure because there is a screw in the palate to expand the palate and correct the maxilla and the crossbite, the posterior crossbite. A transversal expansion to create space for the lateral incisors. I don't want to touch the lateral incisors at all, nothing, I don't touch anything. And now, after having placed the resin bite blocks to improve the mandibular asymmetry, I do the last part of the occlusal correction, which is a slight distalization of the permanent molar on the left side. Of course, the canine is a deciduous one. I don't care about it. This is the distalization of the upper left molar. On the right, I also distalized a little one, a couple of millimeters, because it's better to have the upper molars a little bit in a super class 1 instead of in a very precise class 1. And with this kind of structure, with this kind of biomechanic, with this kind of anchorage, everything is very easy to be done. This is May. I started treatment, the distalization in April. This is April, the day when we placed the bracket and the wire. 1 month after, this is June, 2 months after. 2 months after, there is a big space between the upper left primary and permanent molars, because I'm distalizing the little bit the left molar. Distalizing means also a tipping, of course, a little bit of tipping. Now the permanent molars are occluding, are touching perfectly, full class 1. Here is another step of the treatment, the stabilization. I overcorrected a little bit the position of both molars. I'm not afraid if also on the right I'm a little bit in class 3 with the molar. I prefer to have the upper molars a little bit more distal in front of a real class 2 malocclusion. And instead of an upper arch, it seems a circle. It seems a circle. It's beautiful. It's not an arch form. It's something round. The same day when I removed the screw and the upper RPE, the upper appliance, I asked the lab to build up a NENS appliance. Same day. In the morning, I removed the expander. In the afternoon, I placed the NENS, because the permanent molars will relapse in a few hours, not weeks, not days, hours. So same day, to maintain the mesial position of the molars. Of course, if I wouldn't have lost the screw, it would have been preferable to use the screw instead of the acrylic pad. But in this patient, the screw were mobile when I removed the palate, the rapid palatal expander. So I decided to do a traditional NENS. After a few months, you see the transition of the second premolar on the left, not on the right. Here is 1 year after the positioning of the NENS. Of course, the retention time is long, but the patient doesn't care. He has nothing to do. The incisors, once again, are splintered because I don't want they rotate again, they relapse in a rotation, in a rotated position. And now you see is ready for the second phase, but the good news is that now second phase will be much easier because I am in a full class 2 in the right and in the full molar class 2 in the left. So fixing the midline and tipping forward the lower left canine will be absolutely very easy, even more if I use fixed appliances.